Um, we need to start the program now, and others will join us as we proceed. This is Ola. I'm the local pathologist, as I said earlier, and director of the laboratory program in Paris Sound. It gives me a great pleasure to introduce Dr. Meghan Davis, who has been practicing family medicine in Hamilton for over 20 years. So, she's an assistant clinical professor in the Department of Family Medicine at McMaster, where she graduated from medical school, and prior to that, from chemical engineering. Dr. Davis is the founder and project lead of the Hamilton Family Health Team's Green Initiative. Dr. Davis is passionate about promoting, enabling, and creating community around environmental sustainability within healthcare, so we can work together towards providing high quality care that will also lower carbon footprint care. Dr. Davis, the floor is yours.
Right. Thank you for that introduction. And thank you everybody for joining us all. This is such a new field, and many of us, we want to do something, but we don't really know how to start. And we all end up, as is often the case, reinventing the wheel. So meetings like this help us collaborate. We were just talking about the importance, Kelly, of communication. So, this is part of it. These are my disclosures. I have been a physician lead at my family health team, so I received a stipend. For that work. I also recently authored a module for the McMaster Foundation of Medical Practice, so I received a stipend for that. That module is about environmental sustainability in primary care. So my goal today is to move us from thinking about this topic to talking about it to doing something. And I hope we can all walk away from this talk today with one thing that you can do tomorrow. So in healthcare, we talk about the quadruple aim of, sorry, I lost my place here. We talk about the quadruple aim of patient experience, reducing costs, advancing population health, and improving the provider experience. So using the same terminology, but in the environmental space, here's what I have found with doing this work in the last 4 years. So those longer arrows, the one going to the earth, well, we want to support initiatives that reduce carbon emissions. And this is complicated because everything we do has an emission, from the Band-Aid to the medication we prescribe. So we try to prioritize that in terms of what could be most significant. And the second longer arrow is we want to spend our time and attention on initiatives that simultaneously help our patients' health. This is the co-benefit of environmental work. It enables us busy healthcare workers to engage with this. The other two benefits were a bit of an unexpected for me, a bit of a surprise. First of all, there's great personal meaning to be found. So that's the smaller arrow leading to me at my desk, because this project has really changed how I live my life, how I eat, gardening, biking, friendships, and really a renewed sense of purpose at work and some resilience to climate despair. And finally, it's created a real cohesion within my office. Just the other day, we were interviewing for a new RN. Staffing is really an issue right now. And the candidate said to us in the interview how much she wanted to join our team because she had heard about us going green. So moving from those very specific benefits, I want to zoom out into the big picture, because medical school taught me about the broader determinants of health. Okay, we have to consider income, education, language, geography. And really, we now need to zoom out further into the most fundamental determinant of health, both human and non-human, which is our environment. So going around the outskirts of this image, we need to have clean air, we need to have clean water, we need to have food, stable weather. And we healthcare professionals, so the person in there with the heart and the facility, we need to have, we're all contained within that environmental space. Sometimes I think we think of ourselves as separate, but we're really part of the environment. Its well-being is, in fact, our fundamental well-being. And it is getting hotter. This graph shows the temperature changes in Canada since 1961. Each stripe represents the average temperature for a single year relative to the average temperature over a period as a whole. And so you can see the shades of blue where it's colder than average years, and then red showing it's hotter. And then you can see lately the stark band of deep red on the right-hand side showing that there's a rapid heating of our planet in recent decades. Now, the goal has always been for us to limit global warming to 1.5 degrees. We're at 1.1 approximately now, and we're probably not likely going to be able to limit it to 1.5 by 2040. However, if we take action now, we can try and limit how much we go over that 1.5. And I'm sure all of us have seen this affecting us across Canada, the fires, the floods, the smoke, the extreme heat events. I've seen lots more tick-borne illnesses, air quality issues, food security issues. So in Canada, those of us in healthcare contribute almost 5% approximately towards emissions. So 5%, so 1/20th comes from what we do. And this puts our healthcare system almost the worst in terms of greenhouse gas emissions in the world, secondly only to our neighbors to the south. So we're that yellow line that's just below the red line, which is the US, the top red line. So because of this, the Lancet Commission on Climate Change has identified it as both the greatest global health threat and an opportunity in the 21st century. So when we started working on this, we really tried to make sure to include that opportunity word. There is an opportunity here to help both the environment and humans, and there's so many co-benefits: food security, healthy cities, mental health, preventing disease. So in doing this work, we can not only reduce that 5%, but in addition, on this green health journey that I'm hoping we all join in together with, we can improve overall health. And this improvement has actually been quantified. The UK is far ahead of us in these things, but it shows that when we work to reduce environmental impact, the positive impacts on human health have millions of life years saved. This is a study from England and Wales. So within my work, I mostly focus on primary care, greenhouse gases, and we can see when we look at the whole healthcare system, this is the Canadian data, that the most significant source in the whole healthcare system of greenhouse gases is pharmaceuticals. Hospital at 25. Hospitals are a close second at 24. But it really was quite a surprise to me because I thought it would be hospitals that would be the largest carbon footprint, but pharmaceuticals are a large part of it. Now, we don't have data in Canada yet to dig deeper into each of those categories, but we do from the UK. And this data shows the carbon sources by activity type and setting. So this lets us pick our priority. So you can see that in the acute care setting, that medicine and chemicals, medical equipment, and the building energy is super important. And you can see in primary care, that big blue dot with the horizontal arrow, that's our medications. So it's really helpful to pick priorities because we can't do everything. So for the hospital folks on this call, if they're interested in engaging in environmental sustainability, there's a lot of guides out there to help you, and there's teams that have come before you. There's checklists like this. This is the Canadian Green Hospital Checklist. And we can connect you with an organization called Peach about how to design a large green healthcare facility. But I'm going to dial back mostly to what I know the most about, which is primary care. So when I started this, I thought, well, there's so many ways to tackle climate change. How do we vote? What do you buy? What do you drive? How do you heat your home? What food should you buy? What crops are you growing? And it's a bit overwhelming. So when I started off this journey, which was quite recently in 2019, after a talk I heard with some friends, we started thinking about our own footprint. Like what should I buy? What should I drive? But then I thought I can have much larger impact within my workplace. And I think we can all understand in medicine the pitfalls of trying to be a specialist in every single area. So we picked to focus on that area of primary care, and we divided our work. So that's me in my office examining a cute little baby. And the two areas that we focused on were how to green our care and then how to green our offices. And when we started out, most people tend to prioritize what they see, which is waste. And they think, oh, I got to do something, I'm going to recycle. But it actually doesn't change much because most of the product's emissions happen, 90% of them happen upstream. But underneath that visible garbage, there's really powerful initiatives that primary care is and health is particularly good at, like those ones listed here: carrying respiratory care, cancer screening, smoking cessation, choosing wisely, which most of us have heard of, plant-rich eating, and nature prescriptions. So we developed initiatives around those 6 aspects, so they're in the one green box of care, and then we documented our progress in the other 2 categories of emissions and waste within our offices. So for our care-based initiatives, we always focused on things that would help our patients and our planet. We like to call this high quality, low carbon care. These are things that we engage our patients with just because they are good for their health. After all, that's what we're all for. And it just happens to have a great help for the environment too. And I'm quickly going to go through those topics. So let's look at first at metered dose inhalers for COPD and asthma. It's a really great example of high quality, low carbon care. So it's low carbon care because metered dose inhalers have a huge carbon footprint. 1 metered dose inhaler is equivalent to about 290 kilometers worth of car emissions per 100 doses, or 200 puffs. Total surprise to me when I started this project. This data is from the UK. It's based on their transportation data and puffer types. For Canada, it's likely a bit of an overestimate. It's probably about 140 kilometers per inhaler, but still significant. And this is because the propellant used in metered dose inhalers, a hydrofluorocarbon, has 1,300 to 3,300 times the global warming potential of carbon dioxide. The higher propellant isn't commonly as used, but it's still sometimes used. And dry powdered inhalers, so the click and inhale versus push and express, are much smaller carbon footprint. And there's a lot of different dry powdered inhaler devices that are listed here. So this is significant because asthma is so significant. It's a common diagnosis. Almost 10% of Canadians have it, hence the huge number of puffers. So with the common diagnosis and the large carbon footprint, metered dose inhaler prescribing is a significant portion of all of healthcare's carbon footprint. According to a Health Canada document, almost 900,000 salbutamol inhalers are distributed each and every month across Canada. So that's a huge carbon footprint. It's also a big opportunity for better patient care because we really shouldn't be using that many Ventolin inhalers. So we know that lowering metered dose inhaler prescribing is good for green care, and there's at least 3 different ways that it's good for quality care for our patients. Here's the first way. One is that 44% of Canadians who have an asthma diagnosis have never had spirometry. 67% of patients with COPD have never had spirometry, so they haven't actually had their diagnosis confirmed, which is the gold standard. The risk for patients with that is that they get unnecessary meds, maybe we're missing diagnoses, they've got unnecessary costs, and really the belief that they have a chronic illness that they don't necessarily have. So we should be doing spirometry for our patients. The second way that it helps with quality care is we can use evidence-based prescribing for asthma. Over-prescribing short-acting beta agonists is risky. And according to the 2021 Sabina studies, the use of more than 2 short-acting beta agonist inhalers per year, regardless of what else you use, is correlated with meaning a steroid added on, is increased exacerbation and hospitalization incidence and mortality. So we're over-prescribing them and it is harming patients' health. So the studies show that even if we know this and we try and prescribe an inhaled corticosteroid to be used, for example, twice a day, the evidence shows that most of my patients don't fill the steroid prescription. And we see that patients are really they do much better if they can have 1 puffer. So combining that SABA with a steroid is a really good idea. And there's dry powdered inhalers that do that very, very well. And they increase compliance for patients. So the third opportunity to improve patient care with less inhaler prescribing is to show them properly how to use the inhaler. So there's so many studies about this, and up to about 70% of people don't use the inhalers properly. And I'm sure you guys have lots of stories about this. It goes up even more with kids and with adults. So even if we've made the right diagnosis, and we've picked the right puffer, if people aren't getting it, they're going to have more hospitalizations. They're going to end up on more steroids, have poor disease control and low quality of life. So those are 3 things that we rolled into our project on meter dose inhalers that can improve your patient care at the same time as lowering your prescribing of meter dose inhalers. And we created quite a few tools around this that are all on our website. We've got a great webinar that's going to expand what I just said. There's an infographic if you prefer to read rather than listen. We've got posters that you can put up in your office to direct patients to ask you about it. A little puffer cheat sheet about all the different kinds of puffers and their LU codes and everything. So the second green care topic we call plant-rich eating. Now, we avoided saying plant-based because we wanted to be inclusive of many different eating habits. So it is low carbon because it reduces the carbon footprint of healthcare significantly and also reduces the burden of animal agriculture. And I'm going to show you why it is a high quality care as well. So just what is plant-rich eating? Well, it's a spectrum of eating styles: veganism, vegetarianism, Mediterranean diet. It's a continuum: less plant-based, less animal-based, more plant-based. Reduced meat, especially processed, reduced red meat, reduced dairy, eggs. It's fundamentally about increasing fruits and vegetables and whole grain intake and receiving your healthy fats and proteins from sources like nuts, seeds, and legumes. These are the main sources of plant-based proteins. Whole grains also have a small amount of, like oats and quinoa. So helping our patients go plant-rich is high quality as this style of eating has an incredible amount of evidence-based benefits in so many body systems. This is the poster we put together on the left-hand side. You can see all the benefits. So typically what I do is I have this poster in my office, and when someone comes in with one of these things, I'll say, well, you have this, you should try and eat like this. And then I basically say, you know, half your plate from fruits and vegetables. I actually put my hand over this poster, a quarter from whole grains and a quarter from plant-based proteins. So let's see, cardiovascular disease, 24% reduction in ischemic heart disease. Diabetes reduces the A1C by 1 to 2%. Cancer prevention, cancer treatment, mental health, liver and kidney. And we have a bunch of tools that give you more information about this. I'm going to skip this slide because I just found out today that they canceled this because not enough people signed up for it. So instead they made a video for patients to watch about it. We do have this bedside reference tool. So if patients, it tells you exactly how much it will change your blood pressure, your diabetes, reduce your heart cancer, your heart and stroke risk, how it helps with your GI health, your liver and kidney health, how much it helps with depression. So it's kind of like how to prove it to patients that they should do this. And this is one of the best changes that we can do to reduce our climate footprint because animal agriculture causes almost 15% of all human-caused climate change. And this is something I basically do every day in my office. Like the health effects are simply astounding, and the benefits for the planet are astounding. I don't know how many of them go. Then I don't think that it's the progress, not perfection, is my what I say to patients about it. I'm not asking them all to become vegan. And interestingly enough, every patient, every clinician and admin team member involved with this project, almost all of them changed how they eat after they read the research. And this topic really took off. So we have a waiting room video called What's for Dinner? That's really cool. We have a recording of our webinar. We have the infographic. We have some posters like the one that I talk about, and I use that poster pretty much every day. Okay, so let's move on to another topic. This one is something that primary care is particularly good at, which is disease prevention. So when we focus on cancer screening and smoking cessation, we can combat climate change because we decrease the intensity of healthcare required, and therefore its effect on that 5% that I was telling you about, its effect on the environment. And we can improve human health, obviously, through disease prevention and early detection, and then less intensive treatments. In addition to that, for smoking cessation, we reduce climate change because the production of tobacco and the distribution has quite a large carbon footprint. And of course, we all know how quitting smoking improves health and therefore decreases the carbon footprint. We have a recording of a webinar on this, and we have a blog on cancer screening and primary care. And I think for me, when I had that additional lens and motivation of what it takes to continue to ask people to help people quit smoking, to continue to do all the cancer screening, it gave me a renewed energy behind those things that I do in my day-to-day work, knowing that it's not only good for my patients, but it's good for the planet too. So the next topic we did was prescribing. So as I showed at the beginning, that is our largest carbon footprint, whether you're in a hospital or in the community. So when we are mindful about how we prescribe, we can improve the health of our patients directly. So we reduce unnecessary side effects of the tests and the treatments that cause physical and mental discomfort or harm, false positive results, and we can reduce healthcare costs. So a lot of this is from choosing wisely. And we can invite them to, instead of a prescription, to choose a healthier lifestyle that has often an equal or higher benefit for them. So for example, if they eat plant-rich because they're motivated because of their blood pressure, they also reduce their risk of diabetes. They also reduce their cancer risk. So it has versus them taking one blood pressure medication. So pharmaceuticals in primary care are about 60% of our carbon footprint. We do a lot of the prescribing in primary care. So it's a huge opportunity. It's changed the way I practice. So where does that carbon footprint come from? It comes from many sources, from the raw materials, manufacturing, transportation, incineration. We release toxins into the air. We release medications contaminating our water. Medications have been found even way up north in the water and in our landfill. So that's the source of the carbon footprint. And there's so many studies on that reflect this is an opportunity to improve our patient well-being when we prescribe carefully and we de-prescribe appropriately. Fewer side effects, fewer drug interactions, lower costs, fewer hospitalizations, less falls, higher quality of life, including less identification with being sick. So there's a little study from New Zealand where they asked people about their ideas about this, because I think a lot of us are afraid of de-prescribing because we think our patients feel differently about it, but they want this. Half of them felt they were on too many meds. They wanted to be involved with medication decisions, almost 3/4 of them, and more than 80% of them were, hands up, I'd like to stop some of these pills. So I'm going to go over a few of the questions after working in this, in creating the webinars and talking to my colleagues and just doing this in my office for 2 years. These are the things that you consider asking yourself before you prescribe or you re-prescribe. So the first one is, have I got the right diagnosis? So the example is puffers. I get every day a request for a repeat from the pharmacy for a puffer. And now I know that many of my patients have never had testing. They've never had spirometry. And I don't have a giant practice. I have de-diagnosed COPD and asthma. So the patient doesn't think of themselves as sick. They don't need the puffer anymore. It's a wonderful thing to do for them. So the second question I ask myself is there anything else that would work? Is there a non-medication route that is effective, if it's safe for the patient to wait a little bit, which for a lot of these things, it's a long-term prevention thing while they're taking the medication. So great examples are primary prevention of cardiovascular disease. When you talk to a patient about using a statin, and there's great decision-making tools for this. The Framingham has a great one where you can show a patient, look, here's the 100 smiley face. Here's what happens if you eat plant-rich. Here's what happens if you take a statin. They're the same. It's the same benefit. For diabetes as well. So is there something I can do in addition? So I have been able to move patients' A1Cs down to below a diabetic range, I've been able to get patients off their diabetic medications. And of course, this is all like, we don't want someone to go, just stop their drugs without talking to us. It's over time that you can see these things change. Their systolic blood pressure goes down. They need less medications for their blood pressure. Is this a legacy drug? So now I have this idea in my head. I know there's short-term drugs, antibiotics, for example, pain meds, hopefully short-term for pain meds, and long-term drugs to prevent things like statins, blood pressure meds. But then there's these in-between drugs that should be prescribed in between, and we don't do as good of a job at stopping those drugs. So classically, PPIs are an example, SSRIs are another one, bisphosphonates are another one. So is this a legacy drug? And if it is, just pause for a second. I do this. I might make myself a note to do it later, like next time the patient's in, I might make myself a little reminder. Do they need that antidepressant anymore? It was 4 years ago when their mom died. How are they feeling? Would they like to try a slow taper? So the common ones, bisphosphonates, SSRIs, PPIs, and this is a study from MAC where they audited and they figured out that for antidepressants, how were patients on legacy prescriptions beyond the typical clinical indications which are listed there? So 3 to 5 for bisphosphonates, 9 months for SSRIs, depression spontaneously remits, PPIs, stopping it after a year for certain people, some people need it forever. Trying to stop it every year, and consider telling the patient when you prescribe it, listen, try to only take this for 12 weeks or so, and then you should go off of it. So 46% of people were still on their antidepressants past that zone, 45% on PPIs, and 14% were still on their bisphosphonates. So legacy drugs. Is it a legacy drug that you're about to prescribe or re-prescribe? And the next question is the problem the patient's coming in to see me for, this presenting problem, could it be caused by a medication that they're taking? So put that in your differential. Common things are insomnia, falls, fatigue, depression, and dyspepsia. So a prescribing cascade is very common. So for example, with depression, you prescribe one drug to combat the possibly unrecognized side effect of another medication. In the US, and this floored me, they found a study that 1/3 of adults were taking a medication that could actually cause depression. So the next question to ask yourself is that medication still needed when you re-prescribe? So we talked about antidepressants. So when they did a study of this, they found that 7 out of 8 people that were taking an antidepressant long-term did not have any exacerbation of their depression when they discontinued the medication. They noted that a very low taper is important. For example, if the patient's been on it for years, it will take months to deprescribe that in a very tapering dose. 7 out of 8 people could do that. And SSRIs have quite a few side effects and drug interactions. Sorry, that slide, it says see appendix for more details. I apologize for that. That's from our infographic that's on our website, which has details about how to do a slow taper. And the last question to look at quickly is, how many medications is this person on? Because that's the single most important predictor of adverse drug reactions, especially in older people. We know polypharmacy increases the risk of falls, and we also know that it can mimic those presenting symptoms of depression, cognitive impairment, and fatigue. So that's the topic of prescribing. We have 2 tools for that, a webinar and the infographic. We really try and make it practical. So we focused on those 4 classes of drugs, and then 2 decision-making tools that we can use with patients. And I have found that when I use decision-making tools with my patients, they often chose not to go on the medications, particularly statins. They're more motivated to do the non-pharmaceutical things. So the final topic was prescribing nature. BC Parks has a wonderful program called ParkRx, promoting nature for its health benefits, especially mental health benefits. And then also that leads to more pro-nature behaviors. So people want to protect the environment more. And there's lots of tools for that. They have this great poster, the one with the pill that's inside a park. That's a really cool poster, and you can put that up. And then we made a video on that, which we play in the waiting room. Then we have our infographic, and then also we have a EMR embedded ParkRx. We can prescribe nature, and we downloaded that into our EMR. So those are the initiatives on green care. Moving to our offices, we divided it into waste and emissions. And I put this after the care because we do know that the most benefit for our patients and our planet comes from changing how we do our care, less how we manage our facility. So all of this information coming up comes from what we did in my own office. So 4 docs, 4 admin, 4 nurses, 4 allied healthcare professionals. We use the Canadian Association of Physicians for the Environment's toolkit, and we made the changes, we measured them, and we looked at the impact on our staff, our costs, and the environmental benefit. And then we created these infographic guides on all the topics, including a procurement guide, like where can I buy my paper, where can I buy my paper towels, things like that. There's a whole set of topics, just a whole set of things that we looked at. Printing paper we use way less of now. We threw out our Keurig. We saved about 3 kilometers worth of exam bed paper because there's no use. The exam bed paper has no medical use, no benefit to patients. So when we think of reducing our waste, I like to think of it in prioritizing your efforts in order of what has the most impact on emissions. So for example, refusing, that's the exam bed paper, that has the most impact, to reducing, so that's our printing paper. All those giant files that we send out to lawyers and stuff are now on CDs, and we don't print much in the office, it goes straight into our EMR. And then reusing, for example, that's a metal speculum, to the last one, which is recycling. And I like this slide because we tend to always jump to recycling, but it's a much more benefit if we start upstream. My office staff they were really proud of what we were able to do. So diverting almost 170 kilograms of paper towels. We reduced our 43% our paper towel usage. That saved us $200 per year. We diverted 23 kilograms from landfills. And Keurig was huge, 25 kilograms of Keurig pods that we didn't use anymore and 3 kilometers of exam bed paper. We saved quite a bit of money from using LED, and we reduced our water by 50%. So the second topic was within our office was emissions, so our water and our LED, which I just talked about, and our heating. We fixed our heating a little bit too. So those are the various green care and green office topics that we come up with. And so how can we support that? A few things I already talked about. These are the infographics where it's basically like a recipe for what we did, how it helped, and how you might want to take up part of that. Very, very, very practical. It's hard to get through your busy day without trying to figure out, where do I buy my 100% recycled printing paper? Or where do I buy those paper towels that are made of recycled content? And we put them into a little worksheet if people want to go through it and use that. The poster series has been really popular. We've had almost 1,300 ordered so far. The PDFs are all on our website. We are super happy for you to make them your own. There's a webinar series that we recorded, and it's all online, attended by a really nice variety of people. So family doctors, but also a lot of allied healthcare professionals, administrators, pharmacists. It's all listed on our website. So that's the website. We had to report our QI, and we found it kind of hard to measure carbon reduction. So instead we measured engagement, which might be something you guys want to measure if you put this into your QI. And we've had great uptake all the way across Ontario and across Canada. And a little bit of New Zealand because my daughter lives there. So to end, I'm just going to do some rapid fire reflections, and that should leave us some time for some conversation. So I found it really helpful to do improved care that also was low carbon, to have that co-benefit as my focus. And within that, I found it helpful to choose projects that would have a large impact, using the data on where my emissions come from. Particularly, we can see from pharmaceuticals. And we tried to make it super easy for anybody else who wanted to do this. So here's the little poster that we made that you can put on your exam bed paper for the exam bed to explain to the patient why you don't have paper there anymore. We also have a little poster on how to measure babies using the WHO guidelines, because a lot of us measure babies on our exam bed paper, but there's another little small tool that you can buy, and we have a little thing on how to use that. Our motto, your motto could be progress, not perfection. So a classic example of that is plant-rich eating with no judgment for people who have plastic speculums instead of metal. Collaborate. We're stronger together. So we collaborated with our university and with other organizations in our community. It's a really growing field, and there's lots of resources that are being developed. So this is an excellent toolkit. It's the Primary Care Sustainability Toolkit that Dr. Iona Hill from BC has put together. And then also the Canadian Family Physician, there's going to be a series of journal articles that are coming out soon, probably next month. And then I just authored, the Foundation for Medical Practice has those self-directed learning modules. There's going to be one of those coming out on environmental sustainability in primary care. Have fun and celebrate your success. So this is a local artist who created a series of plaques for us. Everybody got to put their own logo on. When they did like 4 or 5 different initiatives, and we provided them funding so that they could get a fun plaque. That's one of the offices that does a lot of LGBTQ work. And so they had this cute little unicorn on their plaque. I like the saying, lift from where you stand. Think of what you're good at. Think of what you enjoy. Think of where are you influential. So for me, it's in primary care. That's where you're going to be the most successful. Think of both top down and bottom up approaches. Ours couldn't have started more bottom up. We put on our boots, we got out, we entered our trash cans on tarps, and we measured. This can give you some credibility and enable you to have some real practical progress. But top down is also important. So you want to embed sustainability in your strat plans. So we have been able to be influenced from our trenches and our garbage collecting to both our family health team that has now got it. That's the small little red box that's outlined at the bottom. We just barely made it into our strat plan, but we're there, which means that they have to provide, they have to measure, and they have to provide resources to this now. So it can't just be on the side of your desk anymore. It has to be devoted, it has to be resources devoted to it, which means some people may get the job done. And this is the strat plan for our family health our Ontario Health Organization, which Kathy, I think you told me you just became. So your OHT could talk to our OHT, because we are we're the only one so far who has environmental sustainability in the strat plan, and we'd like you guys to come and join us, and we can share what we're doing together. So people, when we first started this, we had this one giant team, and we all met regularly, and I talked a lot, and they listened, and we did nothing, and that didn't work. So we figured out a way of instead we sliced and diced it. So first of all, you have site-based green teams. They're on the ground. They're telling people about how to get rid of exam bed paper. They're saying, don't spend all your time on recycling. And they're very multidisciplinary, and they're site-based. So that's the McMaster one. And then we had these pods. So those are topics. So they're topic-based, they're multidisciplinary. So the pod on metered dose inhaler was a pharmacist, a respiratory therapist, a physician, admin. And then there's also communities of practice. So those are based on discipline. So we have a nurse one and a physician one. So because they all kind of speak a shared language of what their job is like, so what they can do. And nurses are a phenomenal support energy for change. So get the staff buy-in. So that little bee at the bottom of that was our logo for my office. Its name is CP Humblebee. He's a non-binary bee, and he's on all of our literature and on our little wooden plaque. And this is one of the receptionists from another office who was keen on it. So figure out what people are interested in, put it on your meeting agendas, get grants, get students, go slow, lead by example, always bring food. Food was really helpful for everybody. They attended the meetings if there's food. I hope there's food at your meeting, Kelly, that you're at. Ask for volunteers. You don't know who's keen greedy unless you bring it up. This is Kira from my office, and I had no idea. She's been working for me for years, how important of a value this was for her. Have leadership, both clinical and non-clinical. So that's the marriage that works to get something done. Clinical leadership and non-clinical leadership. So that's myself and our project manager, who's now in med school, which I'm really happy about. Have fun. This is our executive director. He made a hilarious video about commuting on his bike to work. Engage your community. So this is my friend Diane, who has nothing to do with healthcare, but she can do procurement in her sleep because she owned an Eastside Marriott's. I got a playwright friend of mine to write the videos that are that you can put up in your waiting room. Another friend of mine is a real geek about electricity, and she found us the best light bulbs. Ask your family. These are my daughters. So one of them is really good at graphic design. The other one put in all of our light bulbs in the midst of deep COVID. Celebrate it. This is an event we had called Beers at Brian's. We had a lot of plant-rich food, local craft beer and cider, and we hung out and tried to create some energy together. So there are really so many reasons to become involved in this sustainable work for your family, for your patients, to learn, to support equity, to protect nature, to save costs. We saved $6,000 on our new LED light bulbs, to engage with your team at work. My biggest motivations have been my daughters, because when I found out the risks for them and their future, I thought, I got to take some action. And that's getting that knowledge and taking that action leads to this wonderful thing called hope, which helps with that's your best treatment for climate despair. You can reduce that anxiety if you feel like you've got some agency over it, you're doing something. So let's all start. Let's start small and let's do one thing, and then let's gather people around us, like-minded people like you all here on this call, and grow. And let's sharpen our pencils. Nope, I mean, roll up your exam bid paper. Hospitals anywhere, roll it up. It doesn't help. Learn more, figure out what you're interested in. I think Mylene, plant rich is what you're interested in, right? Yeah. Maybe focus on one prescription type of prescription category that you're going to have her think about before you automatically prescribe. Look around you. Who are the people around you? And then start. Because, and I love this quote from Margaret Mead. She says that, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Thanks, everybody. And happy to have a discussion if anybody still has time.
Any questions for Dr. Davis? In the absence of any, I have one to ask. At the beginning of the talk, you sort of mentioned why it is important to start from the bottom rather than from the top down. I want to know, at what level were you able to engage the McMaster system to buy into your dream?
Okay, so we started at the bottom, and at the same time, we engaged leadership all the time, telling them what we were doing, what we were measuring, keeping them back to, Kelly, what you were saying, communication. So I got grants from Eco Canada to hire summer students to help us do the work. That was really important. And once we kind of got something done, then, and we got a little bit of visibility, then I could advocate for their strategic plans to have environmentalism in them. And that probably took me a year to do something to show that we were having some progress. I don't even know whether you need to do that anymore, you guys. This was 4 years ago. The world has changed since then. Everybody's been breathing in smoke. Everybody knows this is a problem. Like fires, you can't escape them. I'm not even sure you need that bottom-up approach. I think you could start at the top, because I think people are a little bit more concerned.
Thank you. Any more questions?
I think when I think of bottom up and top down, I also think that, if you, I was at a conference and Dean Ornish was saying that, even after having a conversation with Bill Clinton, who was at the time president of the United States, like they weren't able to just be like, hey, United States, here's what you're doing from today on. So like when I think of top down and bottom up, I think every level needs to be on board. And so like from people working on the ground to even patients to then managers to then, CEOs, I think So I think the leaders saying, here's what we're going to do, and the people at the ground saying, here's what I think we could add to this, or here's what I think I can do in my, it's kind of like when you were describing, you know, create a big team and then create like a discipline-based team and then create a specialty-based team and just kind of like make sure that every level is engaged. I think that really helps. And when
Maybe
you
we should change the little words from or to and.
yeah.
Right? It's not one or, it's that and. Yeah, because I
Yeah.
agree that it's fundamentally it's people you need to get engaged. And I mean, after you finish, I'm just aware that Victoria has a question. So you finish what that you do, and we'll go to Victoria.
Oh, I was just also thinking because you said, oh, you're into plant-rich eating, and I definitely am. But after running for 6 months a complete lifestyle medicine intervention program and just noticing, you know, like the mental health, and when you were talking about lifestyle medicine being equally effective in many respects as medication, there's this big study, I can't remember, you might know, that compared physical activity to SSRIs, and
Yes. Yep.
so that made a lot of ripples. So really just thinking broad, and wherever patient starts, whether it's like sleep, stress management, physical activity, or food, it's wherever, whatever they're willing to do, whatever they're ready to do, it just all has an impact. So
Yeah. Yeah.
nature, all of these things.
It's surprising how also that if you start exercising, right? So the effects are multiple, you know, versus if you take one pill to reduce your blood pressure. It's just it's there's multiplicity of benefits for you. Um, Getting people to do that, you know, sometimes if you also talk about personally, like I'll say, because I've known my patients for 20 years, I'll say, I changed how I eat because of this. Yeah, and one of the doctors in my group, like you would not believe, he just joined because I kept saying, "Could you join? Could you join? Could you join? Could you be a part of this? I need more physicians." And once he learned about it, he completely changed how he is eating, and I don't even recognize him anymore. Like he's, you know, and he is, you know, he's one of the converted. Like, and he talks to, and patients just look at him and say, "What happened?" And then he says what happened, and then they change too. Victoria, you've been patiently waiting.
All good. Thank you so much, Dr. Davis, for your chat. I really, really appreciate it. And this is something that I am starting to get more interested and passionate about. So really, really appreciate your talk. A couple of things. Are you able to share your email address and your website again? And then
Yep.
also things like your waiting room visit. Are those things that would be shareable between facilities? Like I work in the Emerge, and we have videos playing in the waiting room, and I have no idea if our facility would even be interested in playing that or would authorize that. But I'm like, these are things that cross my mind when you bring them up. Okay, I see your email address.
Everything we have, you can have, and you can make it your own. This is open source. This, we all have to work together without any like, well, I made this, you can't have it. Like, it's just all open source. Every single thing. You can take what I have and you can change and put your logo on it. So you don't, it's all for the good cause. So, and yeah, and I should let you know, so my I have had to take a small step back, I think, as Kathy knows, because my mother got quite unwell. So in the meantime, there is another team who's been leading this project that I'll put everybody in touch with. But everything is mostly like, I can't imagine why you can't use everything. We kind of stopped mailing the posters out because we got people asking for like 100 posters for us to mail it to them. So we stopped doing that. But the PDFs are there, all on the website. I'll just put the website in there.
Right on. Awesome. Thank you so much.
And if you do email me, I'll just warn you that I probably am going to forward it to the project manager, whose email I don't have handy, because I catch up with taking care of my mom.
So just one more question from me. How did you get a family health team involved? Your entire team.
It's because I've been around forever. I wrote the grant for our family health team like forever ago. And I think it was trust. Like I got tapped to say, will you be a physician lead? And I said, I will, but only if you let me do this. And so, and then they still probably, it wouldn't have flown, except that I got to tell you guys, my daughter was on Instagram, of all things, and found out about this source of funding called Eco Canada. And I applied for some grants. And so there I got admin help, and no one says no to free. So I said to the family health team, hey, I've got these free students. And then I applied for another grant and I got a free 8 month of a university grad, because the Eco Canada wants people do this work in this field. So it was, and you guys can apply for grants too. I'll get a look at that website as well. It was amazing. And it helped us have the support to kind of get enough stuff done to get legitimacy. But I don't honestly think you need that anymore. Like, the world is different than 4 years ago. It is much more recognized as being
the thing to do.
vital. Yeah.
I have a question, and I may have missed this at the very beginning, but are there any examples of hospitals that have done similar kinds of interventions?
Yes. So you did miss that. That is Peach, Ontario, and I can introduce you. Shira, do you work in a hospital?
I do not, but I'm just, I'm curious to understand how this is happening in different spaces.
Yeah, so there's a Green Hospital place. I'm going to put in the link for the folks who are kind of leading in Ontario, the Green Hospital movement. And in fact, the physician who took over from me when my mom was sick, he knows a lot about that. And I believe they have contact information there. So that's Peach. And they have this really good hospital green scorecard, and can connect you if you want to work on your heating. They can connect you with all the people who know about heating. You want to work on your procurement, and they have a newsletter that you can subscribe to as well.
Amazing.
I just want to comment that I have been in touch with Miles Sargent, who is leading Peach, and he's super keen. And he even offered me to go to our MAC meetings and do presentations. I was launching my own program, and I was like feeling like, I get really excited and passionate, and then like I get way too much on my plate, and I was like, oh my God, like this is getting, and I'm not even on the MAC meeting, and I was like, who do I email for this? But now we're starting to slowly but surely launch an environmental sustainability working group. And I think that this is going to be really helpful, and I will definitely pass on and introduce Miles, super friendly. And
I might have just his personal email, but so if you have his I don't know, it's his Hotmail account. I don't know if he shares that. Do you have his email?
I do. I don't know which. I didn't.
Okay. So he took over from me with the primary care. So he's a family physician. He does work in a hospital, so he has both of those sort of views, and he's now leading the project within my family health team. And he just got the order of the city. The city just gave him whatever it's called, the city order for all of his involvement with the environmental field. So he's really also very passionate about trees. If anybody wants to know more about trees, that's his other area of expertise. He's planted trees everywhere. So he'd be a good contact, Shira, for hospitals.
Super. Yeah, loop me into any working group that's happening in the area on this, because I'm very interested.
Do you want to just, but you know what? I'm just going to put his email. Hope he doesn't mind, but I'm going to put his email in the chat, because he's probably the better person to email right now than me. There's Miles. And I know that the family health team had, when I last spoke with them, they had a commitment that they were going to provide leadership in this field across Ontario. So it doesn't mean they're going to go in and green your office, but they're going to, like, all the tools that we have, or answering your emails and putting you in touch with other people who've done the same things. They have a commitment to that, and Peach absolutely has a commitment to helping the tertiary care settings to become greener. And have, like, it's good work to do, you guys. Like, it will, if you're in healthcare, is burdensome sometimes, but this feels like it gives you a little bit of meaning and more energy into it. And you'll be surprised at how many people around you want to do something. If you start talking about it, they want to do something, and just start with whatever you are passionate about. So it could be nature. I mean, for me, the thing that's made the most difference to my patients is medication. So I am a much more careful prescriber right now. And patients really are very grateful for you taking the time to talk to them about going off their meds. Well, thank you. Oh, that's probably the one you're supposed to use. Probably that email address, you guys. I think I just have his personal one. Miles's partner and I went to med school together, so I've known him forever. And then we're almost out of time.
I'd like to thank you, on behalf of the Medical Society and the West Paris Sound Health Center, we'd like to thank you for this excellent talk.
You're most welcome. I'm really glad that you guys asked, and you can start creating your, I look forward to hearing about what green initiatives you guys do. Have a good rest of your day, everybody.
Thank you so
Bye.
much.
Bye.
Bye-bye.